Dr. Ashish Atreja, thank you so much for joining today, and I welcome you. So you're based in New York and New Jersey. How is the scene on the ground?
2 weeks ago when I was in the hospital, it was chaos. I would say controlled chaos, but much more chaos. We didn't know the protocols. We didn't know how much more patients are going to come. 80% of our capacity was all COVID. This time when I went last week, I think we know it's bad, but we know how to manage it. We've increased our capacity significantly. So it's getting better since last week, and that's very heartening. I know the plateau is going to last long. It's not going to get better. There are going to be many more mortalities, but I think we have learned how to manage majority of the patients, which is very heartening.
You're the Chief Innovation Officer at a very large health system and a very busy hospital. What steps did you take as soon as you got wind of the crisis? How did your role change?
Yeah, so that's a great question. I think one of the things we realized at the heart of everything is how different streams came together. So the marketing team, the communication team, the chief medical officers and the medical operations, and the digital health team and the core IT team, everyone came together in a command center way. And we have daily to twice daily huddles to around health system wide to say what's happening, what's not happening. And they kind of have because things are changing very fast, from equipments to supply chains to, all those kind of healthcare workers getting sick. There's a lot of moving pieces. And one of the things we started doing was we already have been building capacity for digital health for the last 6-7 years. I lead the digital health innovation center called App Lab there. So we rapidly turned on our capacity in partnership with other groups as well at Sinai to have just a complete online presence. So people can just have what we call as Mount Sinai now, which has been an initiative of us for some time for telehealth. So anyone can come and get an immediate video visit. We also turn on text to talk through one of our partnering groups where anyone can come on the website and just chat with anyone. And we actually enroll medical students and others to be able to do the light touches there. We also turn on our behavioral assessment because there's a lot of anxiety and stress that happens and also bereavement that happens. And we launched a public health, very big research initiative called STOPCOVIDNYC. We reached out to 14,000 patients the first day itself, which is text to enroll and a chatbot. Now we have more than 30,000 people already enrolled into that within a week. The goal is to reach to 1 million plus patients in a very easy go prescription manner. We are able to prescribe right on their phone and activate them into a research registry.
You also run a spin-off, Rx.Health, that came out from the Mount Sinai App Lab. And you recently partnered with AGA to announce the virtual care hub. How is this linked with what's happening within Mount Sinai? Is it more targeted at other hospitals? What is the difference?
That's correct. So in Mount Sinai, we are using the same platform internally, and we're learning what the needs are. And Rx.Health becomes, I would say, a glue which takes that needs outside to serve other health systems and other GI practices. It also works the other way. Rx.Health is also our soundbite, so to speak, or a sounding board to know what is needed in the community, even if we don't feel from Sinai. And things get built, and we take it internally at Sinai. And I'll give a good example of that. Yale New Haven, which has partnered with Rx.Health, actually really had a very big need of tracking their employee wellness and workforce, what's happening to them every single day, because most of them are distributed remotely. So they helped with Rx.Health to create a program for employee wellness and workplace management. And we believe that is such a critical element that we can now plan to bring it within Sinai or plan to bring it other health systems or other GI practices as we are struggling with that. So it becomes a network of networks where there's one platform and we are able to see the needs, but we are rapidly able to ingest the digital assets. For example, in Virtual Care Hub, we put the asset of telemedicine, but not just telemedicine as a video visit, because 90% of the work in a telemedicine is pre-appointment. Make sure the patient comes up, make sure the patient downloads the app, make sure they show up in the room, and the post-visit follow-up. And so it creates a whole continuous ecosystem from appointments to follow-up, but also monitoring and triage through a bot. And the goal is to not only serve the immediate need, of converting inpatient appointment to virtual appointments, but also rapidly build the foundational layer of capacity for digital health. So when the recovery period happens, all the GI practices are actually very much at par with the infrastructure that's needed to provide a high quality care and combine digital with in-person care seamlessly.
Mm-hmm. Coming back to Sinai, how's the GI department in the hospital or the different hospitals? What's happening there?
Yeah, our leadership really under Bruce Sands and David Greenwald rapidly structured all our services. So in fact, instead of having regular so many physicians at Sinai being in the hospital, we actually took turns to be in the hospital. And since 80-90% of the patients were COVID, we actually partnered with GI Fellow, but also to be in the medicine service, taking care of COVID patients. And as a small team actually dedicated itself to the GI service, the GI consults and the leaders. So I think that restructuring was very rapid within 1 week, but very well done. And we refined it over a period of time to meet the surge capacity. Now, one of the things we have learned is that few patients are coming with diarrhea, nausea, vomiting as presenting symptoms. So the more we are aware of that, we don't have to immediately scope them. We are able to actually watch out and do a COVID testing. With COVID, we just watch for it or rule out C. diff and others. So there's definitely overlap with GI symptoms. We are starting seeing more and more anticoagulation now we have to use in these patients. And I'll give an example. An average COVID patient has a CRP or inflammation of around 150, which is one of the worst UC ulcerative colitis patients has before surgery. So there's so much inflammation that leads to fatigue, but that inflammation also becomes prothrombotic to lead to blood clots and PE. And we've already seen a lot of patients coming back with PE. So rapidly, we have changed our protocol for anticoagulation. They're going to be published soon. But the flip side of that is that can lead to some more bleedings in the hospital unit. So we have to be very cognizant of that thing coming to our patient population as well.
Mm-hmm.
The third part which we did for GI population is for IBD. A lot of patients with IBD were on immunosuppression, and they actually pinged us that they want to stop immunosuppression because they don't want to be affected by COVID that severely. So we had to do a mass outreach. So we were able to reach out to the same Rx.Health platform and reach out to 5,700 patients, engage with them, educate them, and also gave them a capability if they want to be monitored on a regular basis. So 40% patients agreed to be regularly monitored. And out of those 40%, when we ping them, 80% people actually follow up and report their symptoms. So we have just created a real-time registry of activating, preventing patients. And that's a great model which can be scaled nationwide, not only for IBD patients, but also we can adapt the same kind of a strategy for our healthcare workforce as well, which may be actually at even bigger risk because of their exposure to COVID.
Mm-hmm. That's an amazing statistic, right? Like, so clearly we seem to be moving towards a digital phase of not only GI, but all of medicine. But I'm interested in your views on, what does digital gastroenterology look like beyond, the telemedicine stuff, which is happening right now?
Yeah, I think this is one of the most fascinating parts from digital GI perspective. I think while the virtual health is obvious, I feel there are going to be three other streams which are going to be very pivotal and they're going to change. I think this is going to be a watershed movement for medicine as a whole with respect to digitization and gastroenterology specifically. Telehealth, virtual health, of course, taken for granted. And it's more than just a video visit. It's engaging the patients before and after. I would say real-time digital registries and clinical trials are going to be the other part. We are actually planning to scale up as a next phase for our AG initiative to set up a nationwide clinical trial network, which is completely digital recruitment. So you can do recruitment through an e-consent bot, which we are doing right now for STOPCOVIDNYC, to actually EPRO capturing, which we have been doing for the last 5 years through NIH-funded initiative, to actually combining the data with EHR to do real-world registries and clinical trial enrollment. The third, of course, there has been a lot of discussion, and Praveen, you've been into the thick of that, is the AI part for endoscopy. And I've started seeing convergence of AI being for lesion detection to others, and standalone startup companies to actually partnership or becoming part of the major GI endoscopy softwares. that's where it becomes rubber meets the road and becomes what we call as transformational. Otherwise, it's a standalone tool which people do not use. I think these all three things, virtualization, video visits, registries and clinical trials, all virtual, clinical care research, and AI part, augmentation part, I think will also create very new models of population health and better align GI, which has been typically fee for service in many ways, with ACOs, population health and health plans for bundles of cares. So I think we never had the capacity. Now we will have capacity post-COVID to be able to go to health plans and negotiate bundles because we are able to look at populations as a whole.
That's very, very interesting. Now, it's one thing to talk about digital health as Mount Sinai, and quite another thing to talk from a private practice perspective. What does the everyday private practice on the ground do right now at this time during this period in preparation of this whole digital phase of gastroenterology that might surface right after this pandemic settles down?
Right. I think one of the key things, this is actually in a way, even though it's a moment of crisis, it's a great moment for capacity building. And the in-person appointments or the endoscopy volume, which was keeping all gastroenterologists, many of us busy, is lesser, lighter, or not there. So that frees up time to actually build operational capacity, digital capacity training, and really optimization. So it's seamless. There's a concept we have in digital health, which is for technology to be really effective, it has to become invisible, right? Like internet is invisible, right? You just use it, but you don't have to say how you go to internet. It just happens, right? So a lot of our work within Mount Sinai App Lab, but also working with AGA as part of virtual health, which is national transformation. And I would say can be a great model for global transformation in GI through partnerships, right? Is to make all the knowledge we have, all the experience we have available as an open network, open knowledge network to everyone else, but also set up a steering group of people and IBD and others to come together to be a guiding force. And also do tutorials, learning lessons, and sharing things through journals and through publications. So we use this time to absorb, assimilate, increase capacity, and make our practices so super efficient that technology is not a barrier. Technology really becomes a facilitator, the way it is supposed to be, but never got a chance to do before.
Mm-hmm. I have, one other question on this whole connection between digital health and healthcare being local. Forever now, we've talked about that healthcare is local and it's very different from state to state, from hospital to hospital, and region to region, right? But if anything, that this crisis has shown that healthcare is both local and global at the same time. Within a matter of weeks, things spread to every part of the globe. So again, I want to connect the dots back to GI, right? How do you think in this whole phase of digital GI that we will get into, how is it going to affect the regionality of healthcare that we are so used to right now?
Right. That's a great question. I think this is going to be a watershed moment, not only in technology but also in practice and research. Right. The practice patterns are going to change. The referral patterns are going to change. You can imagine. I do not know when the government, how long it will stay this that you can practice across the border. This is the first time since I've been to US in the last 20 years, I can actually treat any patient across US in any state. Right? That was possible in India before. I can still treat patients in India, any state, but I could never do that in US. But now I can. So it is possible that may not be taken away. So suddenly, and this is, when you always can dream, right? So I still haven't stopped dreaming. Can I become a global IBD doctor, right? Because IBD care is so much centered around subspecialized center that we see a lot of gap, a lot of disparities in geographical areas, in remote rural areas, to even if you go 100 miles away. Can we completely break that barrier and decrease the disparities, right? By people becoming global physicians in that regard. And that was only a dream, but I think I can see some figments of that dream actually may become real. And there can be many other doctors who may take that, or physicians or healthcare workers in general may take that. I think sometimes if you haven't tasted anything, you never know how it is possible. So there's a concept called self-efficacy, which means I want to do it. I know this is a good thing to do, but I don't know how. And that is stopping me from doing something. It's a lot of literature in smoking cessation to other behavioral health things. But I think physicians as a workforce also have this self-efficacy. All of us as humans do, or lack of self-efficacy to speak, where we say, hey, I do not know how to do it. It's a too big barrier and I'm busy right now. But this movement will increase our capacity and self-efficacy that many of us will continue to march ahead. And I truly wish GI community takes it, that it's not just one or two people, it's actually majority of the GI take it and become actually more national workforce than just hyper-local workforce. Knowing that some of the procedures will remain always hyper-local. But the reach from a outpatient practice, from a consultative nature, can become much more regional and eventually global.
That's very interesting to hear. Thanks for sharing all these points of view. One final question. Now, you're talking about dreams, and you are a gastroenterologist and a technologist at the same time, a very rare combination. Now, my question is 5 years from now, and if you have to look ahead, just 5 years from now, how is the GI world going to look from your lens? If everything that you imagine comes true.
That's a tougher thing, and you know why, Praveen? We have learned that you can never predict what happens in technology 5 years from now. And Bill Gates has a favorite saying: "You overestimate impact of technology in the short term, but you completely underestimate technology impact in the long run." Patient portals came. I was doing my informatics fellowship in 2003. We thought, "Oh my God, patient portals are no-brainer. Within 5 years, everyone would have it." It's coming closer to that, but it's 20 years right now. It's still taking time. On the other hand, some things happen faster than others, right? If I have to see what things will happen for sure in 5 years, I think augmentation through AI for visualization is given. That's gonna be not a good practice if that doesn't happen. Digital care in terms of pre and post procedure. I mean, we just give a paper sheet to our endoscopy for patient for colonoscopy. 50% of them forget where they have kept the paper sheet before they come for colonoscopy. 1 in 4 patients have poor bowel prep, right? 20% to 30% patients never come back at the right time. We have no way to recall them, especially in academic centers. With our initiative with the AGA for transformation endoscopy, completely that's going to be automated, right? So our all practices will not only be seamless, will be same standard in digital standard, not just clinical protocol standard, but digital protocol standard will be similar. And that's where societies have a big role to play. Research will become much more global and much more national. Most of the studies which we are doing are 1 center, 2 centers, every time retrospective. They're going to be platforms, registries for mass populations, like very much like STOPCOVIDNYC. And we're going to have like 300,000 people, GI people in the GERD maybe, or 20,000, 30,000 IBD registry globally or nationally. And so we can actually do better research, better recruitment. I think it's going to be fascinating time. There may be a little bit role changing for gastroenterologists, and I think that's great. There's a lot of Vinod Khosla talks about you do upskilling. So technology enables us a generalist to become a specialist to become a super specialist, or more importantly, everyone can do more than the top of the license with technology enablement. And I think we'll become much better population health, delivery care experts. We'll be able to provide not just science of medicine, but delivery of care delivery of medicine much more better in our practice. And we'll become much better national and global researchers by adopting this in a meaningful manner.
Excellent. Thank you so much. Stay safe, you and your team. I wish you all the best. Thank you, Dr. Ashish Atreja.
Thank you, Praveen. My pleasure. Take care.